particularly with there not being sufficient beds and not being sufficient support services across the entire state. And we had great testimony from our hospitals explaining and giving a background and context on what the situation currently is on the ground. And so today is a follow-up to that conversation. Today we are specifically going to be hearing from Judge Marina Sabetti, District Court Mental Health Court of Montgomery County, Carrie Guthrie Cho, the Chief Executive Officer for Cornerstone Montgomery, Jeff Richardson, the Vice President and Community-Based Behavioral Health, Vice President, Community-Based Behavioral Health Programs at Shepard Pratt, Carla Hoffman, Chief of Families and Communities at Shepard Pratt, Elizabeth Arend, representing Nexus Montgomery, and Director, Provider Services Primary Coalition, Mindy Pierce. Also Senior Director from Nexus Montgomery and Population Health and Primary Care Coalition. From our county government and the Department of Health and Human Services, as well as Assistant Chief Administrative Officer, Dr. Stoddard, we've got Dr. Kroll, our Director of HHS, and Dr. Santiago, the Chief of Behavioral Health and Crisis Services. I will note that we, as you all know, have an ongoing crisis right now in the county, which all of you are experiencing in the first person. And so if our colleagues in HHS have to bounce on and off, we certainly understand, in the executive branch as well. We also have representatives from Holy Cross, Suburban, and Adventist Healthcare as a follow-up, if there are any follow-up discussion after the really great presentations that they gave to us on November 1st. So with that, Ms. McMillan, I will turn it over to you to walk us through the packet.
Yes, so the session today is set up in two pieces. And as Council President Albornoz just noted, we do have 4 people to present to you. Judge Sabetti is interested and will tell you about her comments on how a lack of capacity in the mental health programs does impact the mental health court, which the council has, of course, been a very strong supporter of. And so we're very glad that you can be here today. And then as part of the last discussion, there were questions about increased community-based programs. So Cornerstone is here today to talk to you about the programs they have. And of course, Shepard Pratt is here today because they are one of the largest providers throughout the state and the county of programs to people of all ages, and also have a wide range of specialty programs. And then Elizabeth Arend and Mindy Pierce are going to provide you with more information on what Nexus Montgomery has been doing. Nexus is the coalition of the county hospitals, and they have been working on many aspects of the behavioral health issue, both with Crisis Now and the Stabilization Center and several other things. You did have some preliminary comments at your last meeting from Dr. Leslie about Nexus, but you'll get a fuller presentation today. And then the recommendation is that you would have some discussion around those issues. And then following that, Chief Goldstein and Battalion Chief Kaufman are here to give you some updates related to the general issues about emergency department capacity, ambulance runs, ambulance times, numbers of boarders. I am so thankful that the hospitals were able to have representatives here to join you in the conversation. It's so critical that they're here, but we all know that the hospitals are overwhelmed at the moment. So Fire and Rescue will give you some updates on that, and you'll have some time for discussion. I will say that, of course, when you had your first discussion in November, we were hoping that some of the COVID crisis for the hospitals was easing up, but they were seeing more visits because people were coming back to the emergency departments after having not gone to them because of COVID. We're in a different situation now, but the committees I know are very interested in continuing to work on this issue in the long term for when we get to a new sort of status with COVID, that we need to make sure that we're addressing these capacity issues for the long term. So with that, Council President Albornoz, if others had opening comments, or we would turn it over to Judge Sabetti.
I don't believe any of my colleagues have opening comments that they'd like to make. I do want to mention Council Vice President Glass will not be joining us today. He's a member of the HHS committee. He's feeling under the weather. We wish him a speedy recovery, but he will not be joining us this morning. But I'm sure his team is tuning in, and so we hope that he gets better soon. So who's the first up for presentations?
I think that's me.
Judge Sabetti.
Great.
All right. Thank you very much, President Albanese, and thank you, Ms. McMillan, Chairman, council members, colleagues, friends. I want to thank you all very much for this opportunity to appear before you today. It truly is my honor and my pleasure. As Ms. McMillan stated, my name is Marina Sabetti. I'm a judge in the district court here in Montgomery County, and I am the coordinating judge for our mental health court. I, along with my wonderful colleague, Judge Eileen Oliver, as well as our administrative Judge Koch, preside over both the mental health court competency docket as well as the mental health court participant docket. I'm going to give a very brief overview. I know the council is somewhat intimately familiar with what we do, but for those who may not be as familiar, I just want to lay a little context, a little meat on the bones, if you will, before I jump into the facts of what we're discussing here today. So the mental health court competency docket was essentially established in 2018 in order for the court to be able to better wrap its arms around the mental health population in our court system. We wanted to more readily identify those with competency issues and those who should be transferred to the state hospitals. Indeed, Montgomery County has the highest number of persons in the state hospitals from any other county in the state. It's kind of a dubious honor, but it does indicate to us that we are at least identifying those persons who truly need this assistance. And we believe that it's very helpful. We work very closely with the state, with MDH, for which I am extremely grateful, which better facilitates reentry of these persons from the state hospitals into the community pending their trial. And it also helps us to identify people who are appropriate for our court. And that's what I'm going to call our mental health court participant docket for those. And that's what, when people think of our mental health court, I think that's what they think of. It's essentially our group of participants that either take a plea or come in as a diversion, where their case would be dismissed after successful completion of our MHC program, which is generally in for a period of 12 to 18 months. Essentially, the goals of our program are for folks to create that very best version of themselves, and of course to avoid recidivism, which not only benefits the individual, but of course benefits the community as well. We are trying to prevent what many in the problem-solving court community like to call doing life on the installment plan. So to date, when MHC began in 2017, we've served 176 persons. In fiscal year 2021 alone, we served 75 persons. During the pandemic, we didn't miss a beat. I got to give a quick shout out to my team, which also includes our wonderful Phil Andrews, as well as other representatives from the state's attorney's office, as well as OPD, as well as members from DHHS, our clinical team, as well as parole and probation, as well as all the stakeholders that we deal with. They really were instrumental in ensuring that our participants were not hindered being in our program even remotely. I remember that Sunday evening meeting before the court closed very, very clearly. And of course, we've had tremendous community support, particularly from the council, for which we are exceptionally grateful, and we appreciate the collaboration with all our stakeholders, including DHHS, sheriffs, and just any number of other stakeholders in the community. So we've had a total number of graduations that have yielded 79 graduates, with a recidivism rate historically between 10 and 15%. The highest number of graduates so far was actually in October of 2021, That's our fiscal year 2022, which was 16 people. We had 7 in April 2021 and 12 in October 2020. We are presently at 41, primarily because we just graduated so many in October, but we're intaking new persons now each month. Unfortunately, however, over the last month or so, we've had at least 2 persons who had to ultimately withdraw from our program. And these are the 2 persons I'm going to be focusing on today. I would like to talk a little bit about that despite the fact that we believe that we have been successful and we very much appreciate the opportunities we've had in our 5 years now in operation, we have identified certain barriers, particularly for a category of participants that I will call, and I think most people on this call will recognize as high risk, high need. High risk of recidivism, high need psychiatrically, often with co-occurring substance use disorders, etc. And many of these persons need the residential rehabilitation programs, the RRPs, which of course provide assistance in the form of intensive psychiatric rehabilitation in a supervised residential setting. And it is the 24/7 RRP type, that sort of protective environment that focuses on this therapeutic support. It includes medication administration and supports to work on rehabilitation goals, etc. And it is this high-risk, high-need population that needs these things. Unfortunately, there are very few of these beds open. And this fact, I believe, is causing us to underserve a population that desperately needs our help. And to illustrate, I want to go back to those 2 participants for a moment. Essentially, they withdrew ultimately because we were not able to access the level of care that they so desperately needed. We knew that in order for them to be successful, that these persons, and for these persons actually to complete our program and to be successful beyond our program in the community, they needed this type of support. We know this because we tried to place them in other situations in which they ultimately could not succeed. And even more tragically, these individuals each willingly waited almost a year in jail for such placements in an RRP to become available, but those placements never came. And specifically, one of these participants waited from April of 2020 to March of 2021 for an RRP bed in Montgomery County and was never placed. Although he had often been placed in segregation in his years in the criminal justice system, and he had been involved for years and years, it was an amazing thing to see his transformation in jail. He was no longer in segregation because he had hope. And he really, really wanted the help. And the amazing thing is he realized that he needed the help, and he had become very invested in the team, and of course the team invested in him. And oftentimes, and I'm sure a lot of the clinicians and the other members on this call will recognize, well, this person's really not ready for change, that's why they weren't able to do it. That's not the case here. He was totally ready, but we desperately lacked the tools to help him. And after waiting so long in jail, we ultimately tried to put him in a place using homeless housing. Now, this was less than ideal, but after being so long in jail, we didn't want to keep him there because that is certainly not therapeutic. And perhaps even more importantly, we had no idea of any time frame. This is critical, as I'm sure you're aware, is that when you're trying to plan, which we try to plan for our participants over the long haul, it is very difficult to case manage when you don't even know when a resource will even be available. Goals of mental health court are to relieve the burdens on the system, not to create more. And in order for us to be able to do that, we have to be willing and able to plan. So this particular gentleman went to the Dorothy Day shelter for a month and ultimately moved into an apartment through the Housing Initiative Program, which is a great program, in August of 2022 while receiving mental health services through Cornerstone ACT team, which props to Cornerstone ACT. That is the highest level of care in such a setting. But unfortunately, after being in his own apartment in less than a month, he did not take his medications as prescribed. He demonstrated poor self-care skills, leaving trash, dishes all over his apartment. He relapsed into substance abuse and engaged in dangerous and risky behaviors by allowing other persons to stay in his apartment. And while HIP is certainly a great program and may be great for some, it is housing with case management, with supports that check on the individual once per week for 15 minutes to make sure they essentially, do things like pay their bills and follow the housing contract. And that's essentially it. It's not an RRP level of care. And this individual, unfortunately, clearly lacked the coping and the life skills to live safely on his own. And he needed that 24/7 RRP type of protective environment that focused on these therapeutic supports, but again, was not forthcoming. He spent about another month and a half between August and December in jail, but to no avail. No RRP or other places emerged. I very much remember vividly the day in mental health court in December when it became clear that there was really nothing else that we could do for this individual. His probation case was essentially timing out. I have to tell you, there was not a dry eye in the house, including the individual, including myself, including Judge Oliver. 2 judges don't generally preside over our hearings. I was actually on leave, but there was no way I was going to miss his last day in our program. And it was probably one of the saddest days in MHC. I think he benefited from the support that was created by our court, but he desperately needed the services that we could not provide. And I rarely say things like I'm about to say, but it was truly a failure of our system. And I racked my brain as to what we could have done differently. I've talked with a number of folks, but there was really nothing else that could have been done. And unfortunately, we had another participant who had a very similar situation. December was a very tough month for us, who, again, waited in approximately 1 year in jail for a placement. And he too was about to time out. And mind you, a lot of our participants, we don't have the, I use this term loosely, but luxury of having someone with even that much backup time to safely have them before they are out in the community. Because some of the matters in district court wouldn't support that length of time. But he was offered an interview with a general level RRP while he was in jail. They declined his admission based on his assessment, recommended that 24/7 level of care, which was not nor ever has been available. He was offered HIP housing like the other gentleman, but unfortunately decompensated at the crisis center before he was ever even in his own place. The plan was never ideal. We had reservations about it from the beginning, but it was the only option available for him not to be in jail. And the other very unfortunate thing is that this particular person has a great deal of anxiety over new situations. It triggers the voices in his head telling him to flee. So a lack of stable environment provided, like would be provided by an RRP, was obviously very detrimental to his progress. He did bond with our court, particularly with one of our behavioral health techs. Again, there was a level of caring and stability that he never experienced, but MHC can only do so much in that regard. And he really needed that 24/7 level of care. So it's not often that I lay out a problem without a solution. I don't like to do that. That's not what we do in our job. That's as a judge. But I recognize that this is an issue that's complicated. And I am ever so grateful to be able to address you today and to be a part of this conversation. What I do know is that we do need to find some way to create more opportunities for the forensically involved people to get this RRP level of care. I think it is critical if we truly want to be successful for serving this population and for the safety and service to the community. I recognize that RRPs are generally the pecking order, if you will, is to give them from the state beds first. So those who are in the community and competent are not given any priority, and it really is a crisis for those with those high risk, high need categories. So I thank you very much for taking the time to listen to me, and I'm happy to answer any questions that anyone might have, and I'll answer them to the best of my ability.
Judge Sabetti, thank you so much. That was, well, first of all, thank you for your service and leadership, but thank you for sharing those two stories, which are a perfect illustration of the complexity of the system that that is fractured and challenged in many ways. We've got amazing people working really hard, but it's just hard for everybody to do their jobs individually because of that fracture in the system. So thank you for that. What we're going to do is after the four presentations, then we'll open it up for Q&A. So colleagues, please hold off just for a couple, for some period of time. Next, we're going to hear from Ms. Carrie Cho, the Executive Director of Cornerstone Montgomery. I had the opportunity to visit one of their new facilities that was recently reopened after a renovation. I was immensely impressed both by the facility, but most importantly by the staff, who has always just demonstrated just clear conviction and authenticity and wanting to serve our community. So Ms. Cho, the floor is yours.
Great, thank you so much, Council President Albornoz and other council members. I'm very honored to be here, and what we just heard really just upsets me as well. And I actually was feverishly getting some information about vacancies that I'll share later in RRP. But anyway, I am going to go ahead and share my screen. I did do some slides, nothing too crazy. Okay, so I'm here to talk about residential crisis and maybe a little bit about ACT. I'm sure most of you know what residential crisis is. It is community beds that serve as an alternative to a hospitalization, a step down from a hospitalization, diversion from emergency departments, and then just general community referrals. Cornerstone Montgomery has 3 8-bed houses in the community, so we have 24 beds. One of the houses is handicapped accessible. The regs require a staff to client ratio of 1 to 4, and meaning that you need to really have 2 people scheduled, 24/7. In general, regs don't require that you have a prescriber on staff, although you are supposed to coordinate with the client's community prescribers if they have one. If they don't have one, then you're supposed to have kind of an arrangement, maybe with a consultant or something like that. But ever since we opened our first residential crisis facility over 30 years ago, we've always had prescribers on staff. So our model includes crisis counselors, a house manager, intake specialist, and then the prescribers who cover the 3 homes. Back when we first opened the house, we were one of the first in the state. NIH did a study that showed that RCS can be just as effective as an inpatient hospitalization at a little less of a price tag, as you can imagine. So barriers, COVID, it tops the list, I have to tell you. Almost immediately, we had to put new restrictions in place, about 2 years ago now, where we had to say people needed to be tested regularly, they had to wear masks. Normally, RCS is a voluntary open program, meaning people can come and go as they please. If they have a job, they can go to work. If they have, therapy, they can go to therapy. If they have other things like that, they can come and go as they please. With direction from the public health department of the county, we had to tell people we couldn't do that anymore. If they came, they were going to have to stay, because if they left, they could be exposing everyone when they came back to the house. That alone caused many people not to want to come to the program. I totally understand that. Also, just wearing masks can be a challenge. having to be tested all the time. There's just some people who just don't want to do any of that. We do not require vaccines, but we certainly offer them, and we ask what vaccination status is. So some of those restrictions have really affected our capacity. Before COVID, we did 100 intakes a month on average. We are now at about 50 intakes a month. Before COVID, we would usually hover around 97% capacity. And as you can see from the slide, that we haven't gotten near that in 2 years. We are creeping back up again, but I actually think that's going to drop. Because of Omicron, we've had many staff who've had to be out on quarantine, who've tested positive. And I just found out this morning that we have a client who tested positive at our Fenton house. And we had just ended a positive episode at our Granby house. We had 4 people there test positive. So Omicron is killing us, I have to be honest. The turnover in quarantine, we actually are debating closing one of our houses temporarily so we can merge staff. I do not have enough staff to cover the shifts at all 3 houses right now. We have done what we can do with incentivizing, providing bonuses for people who cover, open shifts. And that definitely helped, but it's not enough because Omicron is still hitting us and people are being exposed and having to quarantine or testing positive and being symptomatic. So really, COVID is the biggest issue right now, I'll be honest, with our capacity. Medical issues have always been kind of a barrier in the last few years because so many of our clients have a complicating medical issue. So taking people, who come in and seem to have a medical problem, there'd be times if they were a community referral, we would have to refer them back, to the hospital, to emergency room, or back to their doctor to be cleared medically. There is not an RN or an LPN as part of this model. We've talked about it for years in the state, but it never came to fruition. We got a grant several years ago and we added an LPN to the site. We loved it. It was great. And then COVID hit and residential crisis lost hundreds of thousands of dollars. Usually they make money, but we lost money with COVID and we were unable to sustain the position when the grant ended. But we definitely would like to have a nurse back on site. ED diversion does not happen. The statistics all show it does not happen. What I have been told over the years is that emergency department doctors do not want to refer because of liability. That's what I've been told. The numbers bear that out. We do not see ED diversions very rarely. We get a ton of hospital step downs. People who are ready to leave the hospital but aren't quite ready to go home yet. We get a lot of those. That's never been an issue, but ED diversion has been a challenge. And my understanding is many of the ED docs don't actually work for the hospitals. They work for another organization, and who's contracted out. So I think it's a challenge to encourage diversion from the EDs, but that's certainly something I'm willing to talk about or work on because I think it's absolutely something that should happen. I've also talked several times about diversion with police or EMS, that if they're picking someone up who is obviously having a psychotic crisis, not a medical one, wouldn't it be great if they could just call and say, hey, do you have a vacancy? And you could just drive over and drop them off. My director tells me it doesn't quite work that way. It's not quite that easy. We still need a lot of information that police and EMS probably wouldn't know. So we would have to figure out a process. But again, I think that is something that we should try and figure out. How can we streamline that? How can we make it so there can just be diversion even before they get to the ED? I would love to figure that process out. I was asked to talk about RCS for children and adolescents, why it doesn't happen. And the biggest reason is the regs require a staff to client ratio of 1:3 for children versus 1:4, but it's the same fee for the service. So, you're going to lose money or barely break even with children and adolescents. Usually you lose money. So that's why most organizations that used to do it are no longer doing it and are hard pressed to try and do it again. And I understand it is absolutely a huge need. So hopefully that is something that can be addressed. I've mentioned a lot of these already, but options and ideas for things. Would love to have a full-time RN. I mean, it would make a difference when we had it on site with the grant. We were able to take more medically fragile folks. I know we save the hospitals a bunch of money with diversions and step downs, whether it's an ACT or an RCS. I think they're going to speak to some of those numbers. And, if we could use some of those savings to pay for the RN, I think that would be awesome. We are interested in expanding intake right now. We don't have intake 24/7, which seems silly. It's a crisis house, but that's just the way it's always been. So we would need to look at our structure, and we need to hire more intake people so we could do a 24-hour intake. That eventually would pay for itself, but maybe we'd need some startup money to pay for the first half of the year or something to pay for that position. I know we need more prescriber hours also if we were going to do 24-hour intake. We can coordinate that internally. We have plenty of prescribers. It would just be a matter of, arranging their flexibility and the coverage. My director of crisis services, she threw out an idea when she and I were talking about this. If we had a fourth house, it could kind of be a triage house. The intake could be located there. The RN could be located there. You could do medical clearance, medical review. You could even do detox there if we got that arranged. And then people could be transferred to the other houses. Right now, we can't do detox. We have to send them somewhere else to be detoxed before they can come back to us. So that'd be something to think about if we could do a fourth house. And it's, again, just a brainstorming idea. And just a comment, I know their county is looking at opening the stabilization center soon. And I think RCS will be a logical referral option for people who are there and need more than just the stabilization. That would certainly be an option for people that are still in crisis and need some stabilizing. Oops. The last slide is really just about ACT. I think most of you know what that is. Linda wanted me to just touch on how you get in. Right now, it's really hard. COVID, again, has also decimated that staff. There's waiting lists for all the teams that are in Montgomery County. But you can see that the pre and post data, hospitalizations and ED visits were reduced by 50% for people, pre-ACT and post-ACT, for savings of over $1 million. And that's just for us. I know that Nexus is going to share the data for all the work that they've done on this area. So I do think there's some savings that we've seen that could be rolled into some of these programs to try and help with access and expansion. And again, Cornerstone Montgomery is happy to participate in any of those conversations to make that happen. It's a crisis program. It should be able to respond in a crisis. So yeah, happy to have that conversation.
That was incredibly enlightening and very helpful. I do have some follow-up questions that I will ask after both presentations. Thank you, Ms. Joe. On a significantly lighter note, I've got to let you know that the mask you guys gave us at that groundbreaking has gotten more compliments than any other mask I've worn. So,
well, that's great.
Bright, cheery colors. They don't know what the logo means, but they look cool. So, again, very lighter note. All right. Next, we are going to hear from Jeff Richardson, the Vice President, Community-Based Behavioral Health Programs at Shepard Pratt, and also Carla Hoffman, the Chief of Families and Communications at Shepard Pratt.
You're muted, Jeff.
We can hear you, Carla.
Great. Can you hear me now?
Yeah.
Fantastic. Okay. Great. Well, thanks everyone for this opportunity. I'm going to go through some slides fairly quickly. I just wanted to thank both Carrie and Judge Sabetti for their remarks, and that I've been in this field for 35 years, and the system has been fragmented. I think we're making progress, but we have a very long way to go before. And other than sharing with you this lovely slide deck, first, I did want to share with you some news. We did just get approved for 8 24/7 RRP beds, Judge. But to your point earlier, I think we really need to make sure that people accessing that bed simply don't have to come directly from the hospital. And I think that will come a long way. But we were just approved for 8 additional RRP beds in Montgomery County. We are also doing this throughout the state. So moving through these slides fairly quickly, just many of you know Shepard Pratt. I'm not going to go through a lot of detail other than to say that we're in 16 counties in Maryland. We serve about 70,000 folks. And, some of the things we do in one county, we don't do in another for more historical reasons. So I'm going to touch on a few crisis programs and things we do across the state that might be applicable to what we already do in Montgomery County, or might be some ideas that we can further build on in further discussions. But We also are the largest provider of non-public special education, and we actually are in nearly 400 locations throughout the state. So again, just a sense of I think Carrie touched on this, but with someone with a behavioral health need is one person with a behavioral health need is one person. So there's a variety of resources and programming that we try to bring to bear for every individual with a behavioral health need. The description earlier of the two folks described were adults with some significant issues. We also serve a number of children, people with very specific behavioral health needs. So for us, part of the focus is also trying to wrap around that basket of resources and services that individual needs to help them maintain that success. Slide. In terms of where we are in the state, again, we have a series of programs and services I'll go into in a second that are spread throughout the state of Maryland and specifically in Montgomery County. When we talk about, I want to touch a little bit more on crisis and admissions services as we go into another slide. I think Carrie already identified some of the important barriers around residential crisis. We also do a number of assessment referral services. We have a call center for the entire state, so if anyone calls us, we can refer them to services and programming. We have a range of inpatient specialty services. We have two psychiatric hospitals with approximately 400 beds across the state of Maryland. We just opened a new facility in Elkridge in July. Again, some of the same issues that Carrie described in terms of staffing and challenges we're having across every part of our system as well as with COVID. Residential and structured day services. We have day hospitals, crisis residential services. We have about 65 beds of residential crisis services now. We just opened a new facility in Montgomery County, a 16-bed facility that we've been partnering with Nexus on, and very excited to get that off the ground. But again, as Carrie suggested, some of the same issues come to bear with both staffing and COVID that we're trying to surmount. We also do both inpatient and outpatient addiction services. We just opened a hub and spoke program where we're able to provide methadone treatment and provide virtual addiction services across the state. We're working in collaborative care initiatives in both primary care settings and within a number of providers settings. To our telepsychiatry services, we've had to rapidly pivot towards that during COVID. And as many of you have probably experienced seeing any doctor or anyone, we've delivered close to 600,000 outpatient encounters through telehealth along with that. I bring that up because that also does eliminate some of the geographic barriers of someone having to come into a clinic or come into an office and allow us to more rapidly treat somebody. Carla's going to touch on some key crisis services for kids, because I think one of the things that we hear often from our hospital partners across the state, particularly kids, has been a challenge for services post-discharge and on an ongoing basis. And I think the point that I think we're all going to make is that while crisis services are important, being able to support all kids and adults in ongoing treatment is even a more significant need and challenge right now. We need to make sure access is more wide and more available. I mentioned our schools that we operate, but we also are in nearly 200 schools across the state providing school-based counseling programs. And again, in terms of anecdotally, we're seeing huge needs of these kids that we're treating in the schools due to COVID. This has been 2 years of awfulness for everyone, and children have bared the brunt of this. We operate nearly 1,200 beds of permanent housing across the state. We operate our own business. We actually have a partnership with the FDA, and so we have a number of people employed right there, supported employment programs, ACT teams in a number of counties across the state of Maryland, and in-home and behavioral health home services, as well as very specific consulting programs and settings. So in terms of crisis services, I just mentioned that briefly, but we do have 2 inpatient hospitals. One of the things that we've stood up during COVID that's been really important is urgent care capacity. So people could walk into either one of our facilities to get treatment services. We've expanded our virtual psychiatric urgent care, again, to create a wider footprint of access so someone could call, could meet with one of our clinicians and be able to triage their set of needs as possible. Carla's going to touch on our CCF Kids Crisis Program in Montgomery County. We have mobile crisis services in Frederick and in other jurisdictions. We have a children's mobile crisis service in Frederick. And as Carrie did a great job talking before, we also operate residential crisis beds both in Montgomery County and throughout the state of Maryland. So I'm not going to spend as much time on the residential crisis services because Carrie did a great job with that, talking about it. I think that program is a really important one, but I think Carrie brought up some important barriers that we've seen that I think we've been trying to build into our model in Montgomery County, and actually several of our other jurisdictions where we're able to partner directly by providing staff that work within the hospitals themselves to provide that triage. Because as Carrie suggested, a lot of times those barriers in terms of referrals may come from people not being aware and not being able to access those services in a timely way. We're also working with the state right now to come up with a potential bed board opportunity to be able to identify with other hospitals available psychiatric beds and other services throughout the state of Maryland. And I know Montgomery County is also working on that as well. So I'm going to hand things over to Carla to talk a little bit about just our youth diversion, hospital diversion program that we're doing. And then I really want to move through pretty quickly to talking about some other ideas and solutions, because I think that's more interesting than seeing slide decks of all the stuff that we're doing, but what we can do to solve this challenge that we're in. Carla?
Thank you, Jeff. That's Jeff's way of telling me don't talk too long about this one program. So, so I want to talk about this program. It's Care and Connections for Families. It is a program that we operate under contract to Department of Health and Human Services in Montgomery County. It was a pilot program probably 4 or 5 years ago, and it came out of a program in Baltimore, the BCARS program. And I know Dr. Crowell is pretty familiar with that. Basically, the plan in this program is to work with kids who end up at the crisis center in Montgomery County, and for the ones who maybe are right on the edge of whether or not they need to be hospitalized, but they don't really feel good just sending them home with a referral for weekly therapy. They refer them to this program. It's a child crisis stabilization program. We work with kids for basically 1 to 4 months. It's been a little bit extended lately because of COVID, but and in that period of time, we do intensive in-home work. We have a team of therapists and home stabilizers. They go into the homes very frequently in the beginning. They taper off a little bit towards the end. Their job is to help stabilize the families and the child who was in crisis, and to get them connected with community resources in Montgomery County that can pick up their ongoing behavioral health needs. It's a great model. It's a great program. It's shown really good results in terms of rehospitalization or kids being diverted from the juvenile justice system. Lots of good things, but it's got the same kinds of challenges that everybody else does. Go ahead and go to the next slide. So it diverts kids from the emergency rooms and hospitals. One of the reasons is to help with the COVID and the pandemic. But the other thing is that a lot of these kids don't belong in that setting, and they end up in hospital settings because there are no other options. So it's intensive home treatment. We do daily therapy, support groups, case management. This is a team of people who works incredibly hard and incredibly odd hours. So they do home-based interventions. It's much less expensive than ending up in the hospital. And I would say, we've gotten some additional funding for this program this year for the newcomers. which is really good. We have staff that speak multiple languages and in a language line that we utilize. So we're really looking though at, in the last 6 months, the number of children who've been identified with self-harming or suicidal ideation has gone up dramatically. And even referrals to the program slowed down during COVID, even though we know the needs were increasing. As soon as those kids transitioned back into the classrooms, suddenly we started getting our eyes on them in a different way in the school system. And so referrals got really advanced in terms of their needs and also the numbers of kids being referred to the program. So next slide. So this is just the piece where we want to talk about what I think this program could do, given the kinds of issues that you guys have identified in the hospital emergency departments, is to be able to give these kids quicker access to psychiatry, even if it's telepsychiatry. The thing is that telehealth is not a best practice for therapy for children. So where we've been able to make that work with a lot of the adults who've come through the system over the last 2 years with COVID, it's a little tougher to make that work with the adolescents for a number of reasons that I won't go into. We'd like to be able to see more kids in this program. Last year they served 103 families, and that was 103 children and an additional 238 family members. The remote patient monitoring, and we could use more home stabilizers and mental health therapists, and we could be able to utilize this program more as a diversion thing. We also are supposed to be able to provide in this step down from hospitalization or RTC treatment. Because of the crisis situation, they haven't utilized the program as much for those purposes, but it is a wonderful option under those circumstances. We've got a waiting list in the program right now, in spite of the increased funding for more positions. So next thing is remote patient monitoring is a tool. It's a digital tool that will help therapists and home stabilizers monitor more closely multiple times a day how their clients are doing. So if you have an appointment on Wednesday, but today's Monday and you're not doing very well, we would implement these remote patient monitoring to be able to alert us to your needs and maybe reach out to you much faster instead of waiting for your appointments. And then overnight mobile crisis capacity through telehealth and in-person response. Go ahead, Jeff.
Yeah, thank you. I'm in the interest of time, I'm going to kind of just move through the next slides and
That's
just
good.
talk about barriers. This is our programs that we operate in Montgomery County. And again, we can make this available and share with folks later on and when we get to talking about solutions. But we're very focused on children and families, but we also expanded our outpatient clinics. And I think the outpatient community mental health centers really have a role to play in some of the emergent and crisis and walk-in capacity that we can build in the county. So again, nice pictures of the hospital. We'll blow past that. Let's just talk about challenges. Really, I think Carrie touched on a lot of this, but which is around staffing. It's sort of a two-headed monster that we're running up against. One has been, recruitment and sort of a lot of people stepping out of healthcare in general that we've seen, and so recruitment has been more difficult. We have done several wage initiatives to improve at recruiting and retaining people, even in this year, that have been very costly for us to do, but frankly would not be able to operate some of our programming if we didn't. But we've also seen people, because of COVID, we're seeing a number of different outbreaks across the state where people have not been able to work, and most of our work is not virtual. So we need people to be able to staff what we do and be in person and be present for the children, the families, and the communities that we're in. So it is an ongoing challenge again, and we're seeing significant wage inflation, not just at professional levels. We do a lot of recruitment of physicians and therapists that are challenging, but we're also seeing it at every wage level across all of our 5,000 employees. recruitment has been a super challenge to be able to deliver. We have seen a 45% increase alone in demand for outpatient treatment across the state. And the only barrier for us meeting all of that need is our ability to hire people. If we can recruit more people, we can do more in this space. We've talked a lot about COVID, but some of the access issues and the challenging issues we've also seen people who've never come to get mental health treatment reaching into our systems in a more significant way because of COVID. But we're also seeing through our domestic violence center and other places a lot more domestic violence and family-related issues that are compounded by people literally living and being with each other more often in their own homes, poverty, and as Carla said, also we have a large undocumented group of folks that we serve, and our ability to treat them and for them to access care has been a challenge. Some of the solutions, I think we always will talk about funding, but I've been doing this work a long time. It's never been funded the way it should be, not just on the public side, but on the private side. I think we need to call more of our insurers to task to be adequately fund mental health and addiction and parity. I think one of the things that we also really need to be very focused in on is not just providing the services within community mental health centers and our facilities, but how do we collaborate with medical and primary care in a more effective way? We've had a very expansive partnership in Baltimore County and Baltimore City with several hospitals and federally qualified health centers to be able to provide services within their settings, and again, link people who don't need more intensive care. And I think Carla just touched on it briefly, but resources for innovation. I think one of the things, we are utilizing a lot of digital tools with our patients, consumers, and families. Technical innovations, I know Carrie's involved in this, but a lot of us have been utilizing ways to do everything from monitor medication to monitor how people's medical health is doing remotely. It's pivoted us to be able to do that, but it's a significant capital investment to do that. I think there's other things that we need to do to finish off with what the judge said. I think we failed a lot of people in our systems because we've asked them to deliver in our structure rather than start where they are. And I think there's some really interesting programs both across the country and that are delivered in Maryland. We're part of a program in Baltimore City that's been able to, it's called Chesapeake Connections, where we actually are able to wrap around a set of services similar to ACT, but also are funding housing through that and other medical services. And we are also at financial risk if that individual gets admitted to the hospital, and we are expected to follow them if they're in whatever part of mental health or criminal justice system they are in. And I think that model has a lot of merit for us to look at expanding. I think the crisis now model is good, but not sufficient to meet all of our needs. I think we also really need to be very focused on providing more urgent access and more access in general through our outpatient and community mental health centers, both in this county and across the state. So, Carl, I don't know if you have any final words. Otherwise, we'll just wait for questions.
No, I think that's it. Thank you.
Thank you.
Thank you both. That was very impressive presentation, and I know just the challenges were tough on a good day, and now with everything we're all dealing with, they're off the charts. I do have questions for you guys too, and we'll get back to that in a minute. The last presenter this morning in this part of the presentation, and then we're going to get to Chief Goldstein immediately after this presentation and we finish with Q&A, is Elizabeth Arendt, representing Nexus Montgomery. And we also have Mindy Pierce, the director of Nexus Montgomery and Population Health Primary Care Coalition.
Thank you so much. Linda, should I pull up my own slides?
We can pull them up for you, or you can do it. There you go.
Okay, thank you very much. First, it's an honor to be here today. Thank you so much. As President Albornoz said, my name is Elizabeth Arendt. I am the Director of Provider Services at the Primary Care Coalition, And until this fiscal year, I worked full-time on the Montgomery Cares program, which serves low-income uninsured adults in Montgomery County. Thanks to the support of the Nexus Montgomery Regional Partnership, I've been able to spend half of my time this fiscal year supporting behavioral health crisis services and all the wonderful work that the county is doing since it was not awarded the HHS Catalyst Grant to implement the Crisis Now model. And I have to say, although I was gutted when we first got that news, it's proven to be a blessing in disguise. I've been really just blown away by the momentum and the energy and the enthusiasm around achieving the behavioral health crisis response goals that we first outlined in the proposal, but we've gone so much more just above and beyond that. And as Jeff pointed out, the Crisis Now model is good, but it is not sufficient. And I've been heartened to see how there's been a lot of out-of-the-box thinking. And of course, we're not beholden to the Crisis Now model since we're not wedded to those HSCRC resources. So there's so much happening on the behavioral health crisis scene with Nexus, and I'm really excited to share all of our activities with you today. Next slide, please. So first, just a little bit of background about what Nexus Montgomery is. This is a partnership between all 6 hospitals in Montgomery County with one goal: to improve health for everybody. Its mission is stated below. Nexus works with community partners to promote health, reduce hospitalization, utilization, and manage total cost of care for our community in a way that no single hospital could manage to achieve on its own. Next slide, please. But I also wanted to include a little bit of an org chart, if you will, of the Nexus program, so you can see just how many initiatives fall under Nexus's scope. And today, of course, we will focus on our behavioral health work. You'll see under the Partnership Program Intervention Committee, they oversee the Behavioral Health Work Group, which we relaunched last year, which also has 3 sub-work groups focusing on high utilization and alternative destinations, which refers to an alternative other than jail or the emergency department for individuals in crisis, a sub-work group that is soon to wrap up on discharge planning, and another that is soon to wrap up on mapping the patient journey. We will also touch on the Behavioral Health Crisis Leadership Collaborative, which got off to a great start in December. So we will touch on these 2 aspects of Nexus's work today. Next slide, thank you. So high-level overview, Nexus Montgomery has invested $2.5 million to expand the county's behavioral health treatment capacity. It provides leadership, facilitation, and we participate in the monthly behavioral health work group with the sub-work groups that I just described. One of the outcomes of our last meeting in November was what we heard was that there was a need for greater community education and marketing and promotion of the behavioral health services that are out there, and assistance with navigating those resources, as we heard from Dr. Marissa Leslie, a psychiatrist at Adventist. If she can't navigate it, I imagine she's not the only one who's having that challenge. So that's where a lot of that work is taking place. Nexus also collaborates very closely with DHHS to support behavioral health crisis changes in behavioral health crisis response and ways to innovate and improve the county's response. And this includes facilitating and organizing this high-level leadership collaborative that includes Chief Goldstein, who's joined us today, Dr. Kroll, who I know is here, as well as Chief Jones, Dr. Earl Stoddard, and representatives from all Nexus hospital systems. And that is really intended to facilitate communication between all parties. Behavioral health crisis touches on work in multiple sectors and make sure that that we're working together and it's all very well coordinated. So a little bit of a deeper dive into Nexus's investments. Nexus invested $200,000 in startup funding to add an additional ACT team with Cornerstone. Previously, the county only had 1 ACT team. This ACT team got up and running in FY18, and as Carrie pointed out, each has a census of 100 patients, and that reached capacity in fiscal year 20. And you can see that the charts below, you can see that difference in the percentage the change in visits, in charges, and the charges per visit and the charges per patient. So we've had a good deal of success in this area. An additional ACT team launched in FY21 to further increase capacity. We also invested $462,478 for Cornerstone to open up a third 8-bed crisis house. This was also an investment made in FY18. 71% of admissions derived from hospital step-down referrals and emergency department diversions, leading to an estimated total cost of care savings of $2.7 million, which reflects a 5.96 return on investment. Nexus also invested over $1.2 million in startup funding to Shepard Pratt to open its 16-bed crisis house in Germantown. It started with an interim location, a permanent 6-bed location opened in October 2021, and staff are working very closely with the Nexus Hospital executive directors to support appropriate diversion.
And Elizabeth, that's a 16-bed facility, the new site.
Oh, the permanent site, the one that opened in October?
Yes.
Thank you. Thank you for that correction. Let's see the typo. Thank you. Nexus has also invested $50,000 in assistance and technical assistance to outpatient mental health centers. This was to support changes in operational workflows to enable same-day access to care and institute just-in-time prescribing capabilities, which is key to helping patients get the care they need in a much faster and more efficient way. Next slide, please. And finally, Nexus invested over $500,000 in startup funds to establish a 16-bed county-owned respite care program for people experiencing homelessness who also required medical supervision, especially after they were discharged from the hospital. So this opened on January 3rd, 2022. Crisis Now implementation. This is the work where I've been heavily involved. As I said, we did not, Montgomery County was not awarded the HSCRC Catalyst Grant funds to implement the Crisis Now model, but the county hasn't let that stop it. And activities have been going full speed ahead since the fall of 2020. So Nexus has representation and participates in several DHHS work groups to implement the Crisis Now model and improve behavioral health crisis response in the county. This includes tremendous efforts to expand and enhance mobile crisis outreach teams, the establishment of a 24/7, 365, no wrong door restoration center to stabilize individuals in crisis and provide follow-up once they are discharged, and efforts to identify additional quote-unquote satellite crisis stabilization facilities while the larger restoration center is being built. This of course is a new build, brand new construction, and it will take a few years for that site to come online. There's also a great deal of work underway to standardize responses to crisis calls. So no matter where somebody calls for help, if that is 311, 911, the suicide prevention hotline, or the crisis center, that there is a standard response across the board for an individual in crisis. I also work very closely with Dr. Leslie, who facilitates the behavioral health work group. This group was started by one of my predecessors at the Primary Care Coalition, and it used to focus primarily on individual cases of high utilizers. The Behavioral Health Work Group 2.0 has expanded its mandate, but its overall aims are to improve understanding, communication, and collaboration among the Nexus hospitals, DHHS, and the community-based organizations that regularly participate. We want to improve patient care quality measures and ultimately reduce total cost of care to Medicaid and Medicare beneficiaries. The sub-work groups that were initially formed last year focused specifically on high utilizers and diversion from jail and the emergency departments, finding those alternative destinations that could provide appropriate response at a much lower cost and hopefully with a much better patient experience. Another work group focused on discharge planning and some of the barriers that hospitals faced in the discharge process and patient journey mapping. A new sub-work group is under discussion. Our next work group is taking place on January 20th, and we hope to respond to the need that emerged in our last county council meeting in November about the need to promote the behavioral health services that exist in the county. I believe a previous speaker referred to the fact that some people don't even know what resources exist And I'm sure there are numerous barriers to accessing them, accessing services before anyone even tries to pick up the phone or walk in the door. So there's a new sub-work group under discussion to focus specifically on that and to try to raise awareness and provide some community education about the resources that are available. And I just included an infographic here. I know you're not able to read the fine print, but this is just an example of just a concrete deliverable that came out of the discharge planning work group. One of the main challenges that work group identified was challenges related to HIPAA and confusion and uncertainty around what HIPAA allowed providers to share and not share, and who could they share it with and under which circumstances. So I read the fine print of HIPAA, so no one else had to, and I hope I made it pretty. So this infographic is now out there to all the hospitals to run it by their internal HIPAA compliance officers and legal teams to make sure that everything is HIPAA compliant, I suppose, to make sure that we take down those barriers and everybody has a quick reference so they can understand who they can speak to, under what circumstances, what information they can share to ease that discharge process and make sure that the information is able to be shared for the good of the patient when they're leaving the hospital and going to another location, another service provider or facility. And finally, the Behavioral Health Crisis Leadership Collaborative. This was an entity that was originally imagined in the Crisis Now Catalyst Grant proposal. And I think as the work got underway last year, the need for this group really emerged in that we know that behavioral health crisis response touches on so many different county sectors. And it was wonderful to see the top leadership in all of these county departments come together in early December. Dr. Raymond Kroll co-chairs this group with Dr. Don Walton from Holy Cross. You also see the additional members there listed on your screen, Chief Jones, Chief Goldstein, both of whom were contributed tremendously to our original Crisis Now proposal. We also have Dr. Earl Stoddard and 2 community representatives, as well as Dr. Rolando Santiago, of course, from DHHS. So this meeting, this group initially met in December 2021. One of my biggest accomplishments last year was to get 4 more meetings on the calendar for 2022, which is no small feat. So shout out to everybody's schedulers that made that magic happen. And so I'm very excited to see this group come together with the hospital representatives and make sure, number one, that everybody is on the same page, and also collaborate on some high-level goals, which I believe are outlined on the next slide. Yes, thank you. So this group is really responsible for the 30,000-foot view. Everybody that speaking today, we are in the weeds every single day. This group is meant to look at at system-wide objectives and targets, determining what matters to us, what is it, what counts, and what do we want to measure. How do we evaluate? How do we define success, and how do we evaluate our progress county-wide? This group is responsible for identifying challenges and working collectively across agencies to identify and implement solutions, facilitate inter-partner communication, making sure everybody is updated on all behavioral health crisis related activities, again, because there's just so many balls in the air at any given time. The group also is intended to advise about the direction of county departmental and hospital policies and procedures related to behavioral health crisis, and advocate for long-term sustainability of all of these activities. This was a critical piece of the Catalyst Grant, and there were funds outlined for this to advocate, for example, for Medicaid coverage for behavioral health crisis services, which I understand is on the agenda in Annapolis. But this is going to be a critical piece if investments like the Crisis Stabilization Center are going to be sustainable into the future. And with that, I will open it up for questions, and thank you very much. I yield my time.
Thank you so much, Ms. Aaron. So this is what we're going to do, colleagues, because Chief Goldstein, we let him know we were going to try to begin the second segment by around 11 a.m. But what we're going to do is I'm actually going to give Dr. Kroll an opportunity to say a few words. I know he's probably been sitting on his hands this entire time. This is an issue very near and dear to his heart. He's been a real leader in a lot of different levels in many different spaces. And when you Google "no rest for the weary," I think an image of Dr. Kroll appears. So thank you so much, Dr. Kroll. I'm going to turn it over to you to make a few comments and then turn it over to my co-chair here, Councilmember Chairman Katz, to say a few words, and then he's first up with Q&A. So Dr. Kroll.
Yeah, thank you, Council President Albornoz. I appreciate it, and I appreciate you all having this moment to hear from our provider partners in the community about all the things that represent challenges. In reverse order, but in no certain order, the Nexus, the work we've been doing on Crisis Now with Nexus Montgomery has been really wonderful, and I want to just publicly thank Elizabeth for her work and participation in helping to support Rolando and the team and our respective chiefs in getting us to a better place on that. It recognizes it's the county's commitment to addressing the serious gap at the level that we can address it. It's not sufficient, as people have pointed out, but it is a strong and solid start. So we're proud of that piece of work. The other things I think are that you've heard over the course of the morning are the lack of beds for psychiatric services across the state is a long-standing issue and has been a long-standing issue. And not just in the county, but across the state. And so efforts to try to strengthen that is something that is obviously welcome. And it's good to hear from our partners their observation about this. We are on the issue of residential rehabilitation beds, RRP beds. Judge Sabetti, I thank you from the bottom of my heart for your words this morning, because it really does highlight a barrier that is long-standing in the state. But it's even deeper and broader, because it is beds that our RRP beds need to be developed in a way that allow them to manage co-occurring issues. Substance abuse and medically fragile and developmental disabilities all occur in human beings at the same time, and we need bed space and programs that have the capacity to do that work. You've heard Carrie talk about crisis respite services, and we need those services, but we also need some greater commitment to accept folks who can be diverted from emergency departments, as well as step down from hospitals, so that we make sure that we can catch this on the front end. I am particularly proud of the work that Shepard has done with its child crisis stabilization, and not just because it's a replication of BCARS or modeled off of BCARS in the program I worked on in Baltimore, but because it makes a difference for children who are engaged to have someone that they're connected to, because the crises rise and fall. It's not just a once and done, it's a rise and fall kind of situation, and having somebody that they're connected to who can respond to those keeps children out of the emergency departments and out of unnecessary hospitalizations in inpatient settings. The work that we're working on the Stabilization Center and Restoration Center is phenomenal and is important. And I know that the county executive is putting a CIP, something in the CIP for this budget year coming up. So you should see that coming across to the council shortly. There's a wealth of capacity in the county. There is still a dearth in terms of capacity. So there's a lot of work to be done, and this is a good start in having that conversation and framing out those issues. So I thank you for doing this, and I thank the members who presented to this point. So I'll turn it back over to you. Thank you.
Thank you, Dr. Kroll. Chairman Katz.
Thank you very much, Mr. President, and I sincerely appreciate you suggesting, or more than suggesting, I guess, that we have this discussion before and again today, and obviously we're going to have other discussions on this beyond today. I want to start out by thanking Judge Sabetti and the other judges and everyone else on this call for you're truly heroes for people in Montgomery County. And you do such a good job that people don't even think it's that, difficult to do. And of course, it is an unbelievable job that you're doing. You're true heroes. But for Judge Sabetti, I think, to every one of your graduations, and it's just unbelievable how we have seen. You've seen it on a daily basis or a weekly basis with the people who were involved in the courts, but just from someone who sees it just from that day and hearing the stories it's truly gratifying. And I can say that about every one of and I have many friends on this call. I was on the board of for Cornerstone Montgomery, and I know Carrie. I've known Carla since I think before she was born. I've known Carla forever, but and Carla, you didn't have to say it yes that quickly. I didn't know you that when you were that young. But bottom line on this is that we need to figure out where we're going to go from here, what we really need to go from here. We need to figure out how much is it going to cost for us to get there. And you know, we all know that the enemy of perfect of good is perfect. And so we have to say where we're going to be on a blueprint to get ourselves. We might not be able to get to the most unique spot that we want to be in, but we certainly want to get to the point where we are getting to those best spots. I think we need to figure out what our partners can do with us, and it's not just, well, they should be doing this. We need to work with them. We need to work with the state. We need to work with the feds. We need to work with the private companies as well. We need to figure out what's the best step forward, and we need to do it. We just can't talk about it. We need to do it. And so I do have Ms. President, I'm going to turn it back to you because I know there's others who have many more questions than I on this, as I do on this. But what happens, just basic, what happens if someone does not have insurance? What happens to that person, whether it be with Cornerstone Montgomery, what happens to that person?
When Maryland switched over to fee-for-service back in 1997, people are eligible for services even if they're uninsured with several, requirements. They have to, if they're coming out of the hospital, if they've been homeless, if they've been participating in the public behavioral health system, they'll be eligible for services. And usually what happens is they'll work with like us or Shepard Pratt or somebody else, and then we'll help them apply for Medicaid and all the entitlements that they're due. So most people who are uninsured can get served quite, quickly in the public behavioral health system if they meet those eligibility requirements, meaning, low income, they have the mental health diagnoses, they've been homeless in the hospital, all of those things. So we have quite a lot of them, at least initially. Usually most of them do end up being eligible for Medicaid and they don't stay uninsured for long, but some stay uninsured.
The only thing I would add to that, there's another group that's probably even more challenged to access care, and that's folks with a little bit of insurance, meaning there are a lot of people that have very poor company-sponsored insurance coverage that have less access.
Yes.
And there's fewer and fewer providers that take private insurance and cover the scope of services you just saw Carrie and I talk about. And so that creates a bubble in the public mental health system. It doesn't need to be there. And I think it really requires us to do more work in ensuring access. There are, in many jurisdictions, there's plenty of access, but you have to pay for it. And most people cannot afford to do that and don't have out-of-network coverage to be able to offset that. And that further progresses waits and delays in getting access to care.
Yeah, because most private insurance doesn't cover most of what we do. Private insurance will cover the clinic services, and recently we've gotten private insurance to cover residential crisis. But they don't cover anything else. They don't cover supported employment. They don't cover residential. They don't cover, supported living. So it's kind of tough. You have to have Medicaid in order to actually access all the services that we can provide. This private insurance is very limited on top of what Jeff just mentioned.
Is there a lifetime limit from private insurances and from Medicare? Is there a ceiling on how much they will pay for these services?
So it is a mixed bag by different payers. Yeah. So by private insurance, it really depends on what the employer is willing to fund and that particular plan with whatever particular vendor they choose to select. But there's typically high limitations, particularly on behavioral health. And it's done on Medicare, there's certainly limitations on inpatient. If you have Medicare, that's another group of people that have terrible coverage other than inpatient and some outpatient coverage, but not the scope of the continuum that Carrie described for adults. And again, children who are under their parents' plan are really, really challenged to find adequate coverage.
You know, and I'm going to turn it back over to you, Mr. President, in 1 second. But it used to be, I don't know what it is at this moment, but it used to be that to incarcerate someone costs about $35,000 a year to incarcerate that person. Obviously, depending on the situation of the person, but there are certain things that we cannot afford not to do. And if we are willing to pay $35,000 or whatever that number, which I'm sure is higher today, to incarcerate someone, we need to figure out what we should be paying in order not to incarcerate that person. And I have said time and time again, and it's going to be one more time today, that that's the first cost to incarcerate. The next cost is the cost to the families, the cost to the community, I see head shaking with me. And so we need to figure out, just from an economic standpoint, and this is much more than just an economic standpoint, this is an emotional standpoint, but just from the economic standpoint, what we need to be doing in order to get each individual person to that better place in life. So with that, I'm going to stop preaching, Mr. President, and I'm going to turn it back over to you. Thank you very much.
No, thank you, Chairman Katz. And actually, I like it when you preach. It benefits all of us. Honestly, I really do. All right. So now Councilmember Rice has a couple questions. And then Councilmember.
Well, thank you very much, Mr. President and Mr. Chair. So I want to talk about capacity because many of you have discussed capacity, and there are two things that are at play here. One is that whether or not the state acknowledges that we don't have the capacity that's necessary, which we know internally we don't have the capacity, but has that acknowledgement been given from the state? And then the second part of my question is, when we look at facilities like Holy Cross Germantown, unfortunately I spent a lot of time there over the past couple of days, but know that there's land that's there that's available. Are there opportunities for us to look at expansion so that we can build that future capacity that we know is needed today, but we know isn't going away? I mean, and I just want to second what's been said so far in terms of the stressors that are on this community that aren't going anywhere. You know, when people reference January 6th, when people reference climate change, when people reference social unrest, all the things that weigh, in addition to COVID, but COVID is just one small piece of what we know has continued to labor many people when it comes to mental health and well-being. So from that standpoint, what are our thoughts on those two questions?
Well, I can speak just quickly to the capacity for residential, since that's what Judge Sabetti mentioned. So at any given time, Cornerstone Montgomery has between 6 and 15 residential beds vacant at any given time. Sometimes we don't get referrals very quickly, except if it's the 24-hour ones. Those fill almost immediately. So I can tell you that right now we have 10 openings, and only one of those is the 24-hour type. But it's been open since October. But it's a female bed, not a male bed. So that is definitely one of the issues, that 24-hour beds are definitely more of a need. Now, we could do some reorganizing because some of our intensives are in our apartment communities. They're not 24-hour though. So if we could get rid of some of these apartments and open a house, we could have a 24-hour, we could expand the 24-hour thing. And we've been talking about how to do that. It is in our strategic plan. So we recognize that we have to do some of our own reorganizing, but it would be incumbent upon the state to recognize this need as well and allow people to change some of their housing from the general level to intensive, but they haven't been willing to do that in years, and they don't want to expand. I know they're doing some expansion now because they want to get people out of the state hospital, but that's not going to help Judge Sabetti. So I just wanted to put out there, that's what we're seeing in terms of the residential capacity. We always have vacancies. We always have openings, but they're generally the general level. And if they're the intensive level, they fill pretty quickly.
I'm sorry, go ahead. Please.
Judge, go ahead.
No, I just wanted to add to that I recognize, and actually in preparation for speaking today, I reached out to our justice partners at LBHA, and I know they have a tough go because they have to help manage where people go in bed space. And I know that the state mandates that it's the people coming from the state hospitals that have priority, which leaves those community-based, even though ours are forensic, much like what's coming from the hospital, it leaves those in the community sort of in the second or third tier down, which makes it very difficult. And in talking with LBHA, I know that they have a lot of really good ideas about trying to fill the gaps that they perceive in the system. And as I said, I don't feel equipped necessarily. I'm sort of trying to stay in my lane here today to make recommendations, but I know folks at LBHA and others had some great ideas, including funding an RRP-like group home. It couldn't be an RRP per se, but something that was from the county, because as a result of that, there would be a lot more latitude in terms of what could be done. They were also talking about behavioral pre-release center, whereas we have the pre-release center now, try to make it so that it's a portion of it that would be strictly for behavioral health. Supportive housing with highly intensive case management services. These are all things, again, I take absolutely no credit for them whatsoever. The wonderful folks at LBHA, Regina Morales and Kamarla George, I know have been putting heads together that in terms of what could be done moving forward to identify, again, some other arrangements that might benefit all. So that's all I wanted to say. Thanks so much.
The only other thing I would add, I mean, I think, Councilman, your point earlier around the demand, the behavioral health isn't just one set of people, one set of services. We have a lot of different needs and access points that we need to squeeze at the same time. I think Carrie's point and Judge's point about flexibility on how things is a key. That really works, but it also means there is advocacy related issues that we need to continue to push on. I mean, we have capacity in some places and absolutely no capacity in others. We have people really asking for treatment every day that if we had more staff, we'd be able to provide that care to. We have children's interventional services that need critical resources at bay. We really do need to continue to advocate with our employer partners on what they're doing to ensure that there's adequate health care for people who have insurance. The other things that really help drive people's access to services, it is not a bed process alone. I'm saying this from an organization that runs 2 hospitals. We'll never be able to build enough hospital beds to solve this problem. This is an access related issue across the board. And I think we also need to look at making the available access as immediate and as responsive as possible, and not all crisis driven. We can mitigate even further crisis services if we have greater access to a range of outpatient services and care across all the populations we've identified. And that's where we're going to see success. We see pain points that come along the way. I mean, our hospital partners see it with who gets stuck in the EDs, and that's usually an evidence of what service isn't readily available in the community. But typically, in many cases, it's both an access issue, and if we intervened earlier, we could have kept that person out of an emergency room completely. It's doing all the other great things that you guys are dedicated to doing around housing, employment, safe communities, managing stress, helping people identify how to access care. I think Elizabeth mentioned earlier this notion of even helping people curate and navigate the system. Those of us who are in it get confounded by it. We throw acronyms, we throw names of programs that mean treat it like a secret handshake to get the services. We have to do as much as we can to make this as accessible to as many people as possible at the lowest demand, the lowest intensity level possible. That's how we're going to get through this.
Well, thank you very much to the three of you, and it sounds to me as though, Mr. President, that we may want to think about doing some advocacy at the state level with the Maryland Association of Counties and partnering with our other jurisdictions. And so I stand ready as one of the representatives for MACO to do whatever it is that we need to do to lift this up so that this becomes a priority for this session, so that we can try and see if we can get someone to do something that would give more flexibility. Because I think that flexibility is one of the things, obviously, from the standpoint, and I heard you loud and clear, Judge Sabetti, and to Jeff, in terms of us not being able to build our way out of this problem, but certainly at least flexibility will help with some of it. We'll still need to build some things, as Carrie said. You still have some other facilities that may need to, incorporate some of the things that are there for certain sectors, right? And so whether you're shifting from apartments to townhomes or homes to where you can have, again, it's just about that flexibility. So I think that may help us in being able to work within the system.
Well, advocating for a model that allows you to do that is something that's already happening, and the county knows about it because they have just gotten their SAMHSA grant, but CCBHC is a model that does give you funding and allows you to be flexible because it has so many expectations. So I think that's something that we should consider, as part of the advocacy plan. It may not resolve everything, but it certainly is very broad and covers all of the issues that we've been talking about today.
And there's already state legislation promoting this in that session. So, and then we really need to work on our federal partners to step up to support this.
Yep.
If you could let us know about all those particulars in terms of what those bills are. So if you could just forward that to us so that we have that ability to do that. And then with our federal partners, the National Association of Counties is about to have their legislative session that'll be happening in February here in DC. And so it'll be a great opportunity. I chair our Human Services and Education Committee for the National Association of Counties. So I'd love to be able to take that before our committee as well.
That's great, because our federal folks have co-sponsored a lot of the federal bills that address some of this. So I think looking at it across the country is also a great idea.
Excellent. Thank you. Thank you, Mr. President.
Good suggestions, Councilmember Rice. Councilmember Hucker.
Thank you, Mr. Chairman. Thanks everybody for being here, and particularly Judge. I appreciate all your presentations, and a number of my questions have been answered, and I especially the question of what was happening at the state level, and I agree with the importance of that. Yesterday was opening day in Annapolis. There's nobody here from our OIR. Is there, Ms. McMillan or MDH?
I'm looking to Leslie Frey is on from OIR.
Does Leslie have anything to add about what's happening at the state level and where this is in our countywide priorities? Because I agree it should be near the top.
Hey, thank you, Councilmember Hucker. Yes, I have been taking copious notes, learning a lot today. And yeah, a number of these issues kind of appear on our state priorities. So it has definitely been brought to our attention, stand ready to advocate on any bills that we identify or that our partners here identify with us.
Are there pre-filed bills you're already aware of, or budget initiatives in this area?
Off the top of my head, I couldn't cite chapter and verse to you about pre-filed bills, but happy to get back to you.
Okay, that would be great.
Sure.
So we all obviously agree that we need more residential beds in Montgomery County. Ms. Hoffman, you mentioned that I think you had 103 last year, clients. And you mentioned a waiting list, your waiting list. Any idea, I don't expect the exact answer, but any idea how long your waiting list is?
Well, 2 weeks ago it was 16 families. I think they've gotten it down to 8. I spoke to the director yesterday, and we're hoping to keep at it. The downside of that is that, most of the folks that are coming through the county's crisis center.
Right.
And, utilization of the program a step down is not, we don't shake that tree really hard because we don't have capacity to serve them. So, so that's where I think the expansion of that program would be beneficial on multiple levels. One with the crisis, and then two with the step down families.
I appreciate that. You want to do the work, but you're creating a big challenge for yourself in terms of capacity. Go ahead, Dr. Carl.
Before you jump into that, I just wanted to say that one of the challenges we have to be mindful of is that right now our step down capacity from hospitals to crisis respite and other programs is probably stronger than our diversion capacity, and so I want to make sure that we don't lose one in favor of the other. We have to expand both of those if we're going to expand them.
Yes.
So what's your sense? So 103 clients and a 16-person waiting list right now. What's your view on the total need? Money learning object here.
Honestly, my director asked for 2 more therapists and 2 more home stabilizers in the next budget. And we really didn't see this. This is a program that's a contract program with the county, and it's scheduled to go out to bid. Probably last summer. So things at the county are a little bit behind in that respect. But
why didn't it go out?
We made a decision to delay putting out new RFPs in the midst of COVID because the procurement process was all focused on rapid response to the COVID issues that we're dealing with. Mm-hmm. We've done that on a number of our contracts.
Yeah, they just put an extension on it, but and I said to Andrea yesterday on the phone, I was like, ideally, I'd love to double your program, the size of your program, and so that we can do more with the step down folks. And I'd also like to add some carved out psychiatric time to it. Right now, we're utilizing our own outpatient mental health psychiatrists, and as you all know, that there's a little bit of demand on them right now. So getting things done quickly is a little bit tougher than it used to be.
Okay, and in terms of the market for talent, Mr. Richardson, you mentioned the wage incentives you've initiated to attract staff. Which are the job categories for which you're increasing the wages?
All of them, actually, but different markets, different issues. I mean, from specialist psychiatrists that we've looked at, for example, Carla mentioned, child psychiatrists with particularly trauma skills.
Right.
One area to entry-level staff positions. We've done wage initiatives targeting residential staff, psychiatrists. We just recently went through another wage initiative for our therapists, to be able to further recruit and retain therapists who, part of the other discussion that gets brought up in healthcare a lot is the burnout level. We have staff that are, for example, telehealth has been great, but then you have very little no-shows and you have people literally seeing people around the clock. And so we're also wanting to replenish our teams and recruit where we can. We're also, so it's on every level, but different tactics, different groups.
Yeah.
And some we're seeing greater success than others based on market pressures. And the truth is that one of the good news, we've been talking about all the problems. One of the good things that's happened this year is that we did get a rate increase on Medicaid, which did help out a lot in terms of particularly some of the programs that Carrie was mentioning around residential. We were able to give a significant boost in salary to help recruit staff. And we've done it twice because the demand has been so high and everyone else we seem like we're chasing the market right now. But we can't raise our prices to match salaries to be able to do that. On the therapist end, there's many therapists that can do better in the market, by just simply taking cash. And so what we've tried to do is attract more and more people into our space, but we can't compete on every level for that. So we've done other things like recruited and created our own training programs and other things, none of which is meeting this demand. I'm a therapist, and I'm a bad one. That's why I'm a Bureaucrat. But really, we are all into service now, and and we have staff that are at full hilt. I think there's more we can do to recruit, and at the local level in Montgomery County, there's certainly more that we can do through our local educational institutions to continue to activate interest in this field.
What are those things? What else should we be doing in Montgomery County with our educational? That sounds interesting.
I think there's a couple phases of this, and one is really continue to enhance entry-level behavioral health training programs for people who we're seeing the Great Resignation, right?
Yeah.
We also have people who are wanting to do something meaningful with their lives, that we could provide training programs to captivate people at the unlicensed level first, who want to be human service workers. I think the second piece is create incentives to be able to provide loan forgiveness and other incentives for people who are at a higher academic level. Across the state, there are some incentives federally through medically underserved areas where there is loan forgiveness programs, and we actually have tried to potentiate those in every county we're in, but it goes farther than that. I think we really need to really make this a great dedicated effort towards helping people enter this field. And then the last piece is really working closely with our larger educational institutions, namely University of Maryland and our other academic institutions, to be able to really incent and provide interest and manage the costs of living for people who want to enter the space. So, are there some things we could do to provide housing for people who can't afford to live, because the cost of living is so high? We actually have been providing some housing to some of our staff who, frankly, have been gentrified out of some of their communities, and that is an issue that I know you guys have certainly, I'm sure, thought of with teachers and other demand areas as well. But we have an opportunity to really pivot and really promote people who have never considered this as a career to do that. So it's not a dead issue. There's a lot we can do.
Councilmember Hucker, just to follow up on that very quickly, just to let you know that one of the things that the Human Services Committee did along with Councilmember Navarro and Albornoz was to ask us to initiate a pipeline process for identifying mental health professionals and bringing them. And that collaboration, the work on that has been slowed a little bit by COVID, but they are still working on it. And part of that collaboration is with colleges, with area school systems, and with provider community to find ways to create those pipelines and offer opportunities for folks who are at entry level, as well as career path for them, so that there can be some, we can grow, particularly within Montgomery County residents, folks who are interested and might be interested in becoming part of this process, part of this system. And hopefully folks who live here can move into that pipeline.
That's been the focus that we've had too, is really working closely with the colleges. And one thing that we found successful is hiring current college students as sub-counselors. Like they come in and sub when we have open shifts, with the idea that when they graduate, we'll hire them full time. And that's been a new thing, a new focus we've had to try and expand, kind of that pipeline. We also increased our salaries by 10% last year, looking to do that again for the frontline staff, because that's definitely been our lowest. We've been above the $15, minimum wage for a long time, but we've pushed beyond that now, but we want to do that, growth again. And historically, we didn't have much turnover at our clinic, but that's changed. COVID has definitely changed that. We've had therapists this year that we haven't lost in years, and they've said it's burnout. They want to go into private practice where they'll make more money and can set their own, hours. So it's definitely been more of a challenge to find those therapist level positions than we've ever had before.
I did want to add one other plug, and that is for trauma-informed care.
Oh, absolutely. That's what we do every day.
Because but to even intensify it more throughout, particularly in intensive level beds, DBT, CBT, trauma treatment generally. Everybody who comes into our court, forget mental health court for the moment, just comes into our court has experienced some form of trauma. Right. And it seems that at every level that needs to pervade the type of services that are given. And again, I come from it from a different angle, but.
Absolutely. Yeah. I think I would say the same. All of our clients, they come to us with some sort of trauma. Absolutely. that's kind of overlaying all of what we do is trauma-informed care. We want to welcome people in. We don't want to re-traumatize them. It's something we talk about all the time. Absolutely.
Ms. Wren looks like she wants to get in.
Yes, thank you. I have a number of things to share, but staying on the topic of the behavioral healthcare workforce, I think there may be an advocacy opportunity here also at the state level, specifically on the topic of, first of all, yes to everything Jeff said, and the very real challenges with cost of living and salary. If somebody can't pay their bills and put a roof over their head, they're not going to stay very long. That much we know. But when it comes to retention and simply having the capacity when half of all U.S. counties don't have a single mental health provider, I think we need to think a little bit outside of the box. I've spent the last few days working every contact I know, including at GW, which has a healthcare workforce institute, about task shifting within behavioral health. And it seems like there's a little bit of work being done on this at the state level, not in Maryland yet, but there's tremendous potential there, I think, to be explored as to how to make sure that all behavioral health workers are working to the top of their license, and that we're already starting to talk about using peers in Montgomery County to go out on mobile crisis teams and to staff the stabilization center. That's part of the Crisis Now model. So I think we need to look seriously at task shifting to address some of those healthcare worker shortages. I also wanted to bring up 988 because the whole theory behind Crisis Now is it starts with that 24/7, 365 high-tech call center. That was not a focus of our Catalyst grant proposal, but the idea is that 90% of crisis calls can be resolved on the call, and only 10% need the mobile crisis, right? And of those who receive the mobile crisis, only 10% should need the stabilization center. And so 988 is coming in 6 months, and we know that it is not adequately funded, and we will not have the capacity. If we build it, they will come, and I think we're all anticipating a massive increase in volume of crisis calls. I'm confident. I'm confident that we could address those with adequate staffing and adequate capacity, and that would relieve some of the burden on the service providers who should be addressing more acute cases. So that's also something that I think is I wanted to put on your radar in terms of state advocacy.
Thank you. Since you mentioned that, where is this in the priority list for MHA and individual hospitals at the state level?
And Councilmember Hucker, I apologize. That's going to have to be your last question for now. We still have to get to Chief Goldstein and Kaufman because I know they have hard stops. I actually had a bunch of questions I wanted to ask, some of which have been asked. I'm not sure we're going to get to all of them, but I want to be respectful of everyone's time this morning. So, Ms. Aaron, if you could respond to that last question, and then we'll turn it over to Chief Goldstein to give us an update.
I defer to my colleague Mindy on MHA. We had a meeting with MHA just yesterday. Mindy, would you like to respond?
Sorry, Mr. Chair, I get excited about this stuff.
Hi, everyone. MHA's been working with us. I've been talking to them frequently about their initiatives. They're really working strongly on workforce. Loan assistant repayment programs are big on their agenda, attracting and keeping physicians in Maryland. Also, the medical excellence zone is also a priority to be able to have that license portability between DC, Maryland, and Virginia to be able to have concurrent efforts. But we need concurrent efforts in DC and Virginia to go along with that to make that happen. There would be a central regional registrar to share license information, and once they are in good standing, they could practice via telehealth and see patients from their location. There are also the hospitals are supporting the minimum wage increase. They know that the nursing staffing ratios are something to be focused on for sure. MHA also has behavioral health roundtables, and the next one is in March. They're inviting the Deputy Secretary Sondri to come and talk about that in March.
Thank you.
Wonderful and great questions, Councilmember Hucker. That spawned a really, really good discussion with some really innovative and thoughtful solutions that appeared to have been a lot of agreement on. So we'll get to this more at the end, but I just wanted to, so that we don't lose it. There are a number of follow-ups that were suggested, one being that Ms. Fry provide us with the most complete list of what's happening in Annapolis and what we need to get behind and formally support. I think we've got some of that list, but maybe not all of it, especially in light of this conversation. And I'm especially interested in expanding, well, lots of things, but the recruitment and retention issues we discussed in our last session as well. I'm sure they've gotten worse since November 1st. And they're probably not going to get better, yet the demand is going to be through the roof, particularly in the space of children and youth and adolescents. So I think, we had discussed, and Jeff's already gave some really phenomenal recommendations on for recruitment and retention. And I know that this is an issue that our colleagues in HHS are facing as well. So Ms. McMillan, I would love to talk about as a follow-up some suggestions from all of these distinguished panelists and HHS on their recommendations for recruitment and improvement of recruitment and retention for the county as a whole, and see what we can do as a council to help fill those gaps or help supplement in some way. And this will be music as a former director to our current director of HHS's ears. But Dr. Kroll, I'd love a proposal from all of you. There will never be enough money in the world, and there are a heck of a lot of competing interests. But as Councilmember Katz noted, an investment in prevention and intervention saves so much resources and county resources on the back end. And so it's just, we know all of that inherently. We've all been in this work for a long time. And I've so respected what you and Dr. Santiago have been pulling together. But if there is sort of a wish list, especially given what we're seeing, I'm especially focused on, one of the things that Carrie talked about was their inability to be able to provide as much support as they would like to and they're equipped to because of the staff ratio component and just not being able to break even and being able to serve. Is that a role that the county can help fill in some way? Child crisis mobilization and looking at other innovative ways that are out there. We know it's out there. You have like the best team in the world. And so if you can come back to us with some of those recommendations, particularly in the children and youth space, which is going to just grow exponentially, which I know you're already working on, that would be great. And that would be very helpful. So thank you all. If you'd like to stay on, we are now going to receive an update from Chief Goldstein on the current status of fire and rescue and where things stand currently. Chief Goldstein.
Thank you.
President Albornoz and all the members of the council, thank you very much. The dialogue here, as Nexus outlined, as everybody outlined, the teamwork here amongst the county agencies is immense and leads towards our commitment to helping our residents and the folks that we are here to serve. The efforts have grown greater as your support has gotten behind us and moved to enabling us to have more options and more capabilities. And we know there's better and more as well that we can do. When I was talking to Ms. McMillan last week, as she outlined in the beginning of this session, when we talked in November, we were hoping this would be a much different January to communicate with, and as I shared with the public safety members earlier yesterday, the COVID Omicron specifically impact has been immense and very deep. So Ms. McMillan asked us to address hospital ER capacities and other nuances specifically that fire rescue may be the best to talk to. And Chief Kaufman is with us today, and he's best able to get to that and be able to give you the very concise version. I'll be a little long-winded if you left it up to me to tell you. So, Ben?
Great, thank you, and thank you all. It's an honor to speak with you again. I'd like to start with an update about what we're observing with pre-hospital care and a bit about how we're responding to the more recent challenge associated with this third COVID surge. So overall, EMS call volume is steady with a slight upward trend since the middle of December, and we're on par really with the volume that we saw 2 years ago pre-COVID. Among those calls, we are experiencing a high number of medical complaints associated with viral illness, things like fever, weakness, and shortness of breath. but we believe we hit a peak in these types of complaints right at the end of 2021, so like the last week of December. And since then, we seem to be tapering off a bit with those complaints. And we know that a high number of patients we are transporting are actually COVID positive, which is similar to what we saw with the first surge. What's encouraging this time is that the viral physical findings among the entire population are only mildly impacted. So things like fever, low oxygen level, and high heart rate during the first surge were very high, but not so much this time. And most notably and important, there's really been no increase in cases of out-of-hospital cardiac arrest like we saw during the first half of 2020. So looking countywide at the 6 hospitals, not including the alternate care site in Tacoma Park, we're seeing just a slight increase in overall hospitalizations, but in contrast, the number of patients in the ICU beds is up significantly. Hospitals have added additional ICU capacity to keep up with demand, which seems primarily driven by COVID cases. And now we're seeing just single-digit ICU bed availability in the county. And we believe that this is backing things up through the emergency departments and contributing to the number of boarders. So just like our conversation last time about behavioral health patients, these folks who they require admission but have to remain in the ER because there's no place for them to go. So the issue of boarders and more broadly just ED throughput in general, it's super complex. When I first started looking at this, I thought it should be simpler, like how many beds do you have in the ER and how many boarders do you have? And the difference should be the number of beds that are available to take patients who walk into the ER and come in by ambulance. But I learned that every one of our emergency departments has the ability to surge their capacity above that fixed number of beds. Beyond that, they also move patients around in the ER depending on who's there or who presents in terms of a patient at the ER at any one time. And then the type of patient that boarding also matters with respect to ED resources. An ICU boarder is very different than any other type of patient in the hospital. So the bottom line is that looking at a static number of boarders today versus 2 months ago isn't really going to tell us much. But what I can tell you is that each of our hospitals, including the Germantown Emergency Center and the alternate care site, all have great people working there who are working hard on programs to keep patients moving through the ERs. I want to point out that the state has a couple of programs in place to reduce the burden on individual hospitals. The first is called C4. It's the Critical Care Coordination Center, and it's set up to take phone calls from a hospital that has a patient requiring an ICU bed but doesn't have any room to admit them and match them with a hospital that does have an ICU bed. That program's been in place for a while, and it's been pretty successful. The second program is brand new, and it's set up to help get patients discharged from the hospital faster. One of the concerns from the hospital was that they had a patient ready to be discharged, but they require a commercial ambulance to transport them out. And the contracted ambulance company is so busy that it would sometimes take hours to move that patient. So the state set up this program. It's called MH Cars. When I heard about it, it kind of sounded like Uber for ambulances. So the hospital can go in and request a commercial ambulance at the state, and then it sends out a message to all the private transport companies soliciting the transport. The goal here is, again, to get patients discharged faster via ambulance. Locally, we responded to the ED surge with 2 temporary operational changes. The first was a concerted effort to increase the number of transport units during peak time by working with our local fire rescue departments. And second, we added a transport disposition officer, which we call EMS 700. So this is an EMS supervisor dedicated to monitor ED and ICU capacity at all of our hospitals and help guide the transport destination for our units who are preparing to transport. There's 3 goals. The first is to avoid overloading any single hospital at once and thereby reduce the time that it takes to turn the patient over to the hospital staff and clear the ambulance for the next call. The second is to get the right patient to the right place from the field, so prevent that going to one hospital and then having to move to another place. So we look at things like specialty need. For example, there's certain hospitals that can accept trauma patients and stroke patients. We look at things like, was the patient previously admitted, and we try to get them back to that same hospital called repatriation. We look at ICU admission capability and ED availability. It's obviously constantly fluctuating, so at any one time we try to make the best decision. And then third, we encourage patients who've called 911 to consider alternatives if they're acceptable. So we have a protocol to assess and encourage qualified, stable patients with viral symptoms to stay at home and convalesce there. We also have a telehealth program that enables people from the field to reach a physician 24/7. And then we can also transport to one of our partner urgent care centers. So those encouragements coming from that EMS supervisor in real time is helpful. And based on the marginal evidence we have really in the last 2 weeks since EMS 700 has been in place, we believe we're having a positive impact on hospital drop times. We can't say conclusively that EMS 700 is the solution, plus the problem is so complex that there is going to be no one solution. But EMS 700 benefits our hospital partners as well. So moving forward, there may be some opportunities to share the cost burden to mutual benefit. And just a couple words about alternative destinations. The program has been in place since the start of last year, and we've seen all types of challenges since the beginning. We're continuing to explore ways to increase utilization, but it's not easy. We're currently working on adding the crisis center as a destination to accept some of our low acuity behavioral health patients. And we know that when EMS 700 is in place guiding each transport decision, those alternative destination options are considered more frequently. Some of the things we experienced in the last year is that patients just want to go to the ER when they call 911. But even when patients do agree, we have to then call the urgent care for approval to transport, and the urgent care can refuse our patient, which presents a unique challenge. And then sometimes when the patient accepts, the urgent care accepts, and we do the transport, the patient still ends up in the emergency room anyway, sometimes after calling 911 again for another ambulance to come and move that patient a second time. And most recently, some of our urgent cares have been closed as a result of their own staffing crisis. So with the current program criteria and our partnered urgent care capabilities, the very few patients who do consent and are suitable to go aren't really tying up our valuable emergency department and EMS resources anyway. These are patients that by definition have a very mild illness or injury who would be dropped off quickly by ambulance and should be out of the ER very quickly. So while we may have overestimated the impact of this program as it's currently designed, the mechanism of having ambulances transport to places other than a traditional emergency room is super important that we maintain that. So to tie this all back to the bulk of today's conversation, what we really need are behavioral health beds, stabilization centers, and sobering centers to serve as destinations for pre-hospital patients. Thank you.
Thank you very much, Chief Kaufman. Chief Goldstein, did you want to add anything in the end?
Again, Ben was very concise and detailed, and indeed did a better job than I could have. The partnerships are immense, and the team is there to help and open to your questions and support.
Great. I guess just one general question. How are you guys doing on staffing?
Totally obviously different than the hospital interactions. Knocking on wood and using that message I communicated yesterday, we are almost half of our maximum, which was about 168 folks on January the 3rd. We're down into the 80s today. We've seen some significant jumps in the last week to two lowerings, and I use jumps as a positive phrase as the availability to work has increased. But I will not call us out of the woods and recovered from this surge until we get back to our early December numbers, which were in the upper 20s and low 30s on a daily basis. So we still got a couple of weeks, I think, before we get past those numbers and get back to the 20s and 30s. The men and women of MCFRS are amazing and have been amazing at their dedication, adding extra standbys, extra duty nights, extra overtime shifts to fill in the vacancies for their sick partners and coworkers, and everything is staffed and all of our calls are being answered as it was last year, last month, or any time in the future.
Well, we've come to expect it. You guys just set the standard so high, and we really do appreciate everyone's ongoing dedication and commitment during what has been unimaginably difficult circumstances. So thank you so much, Chief Goldstein, and thank you, Chief Kaufman. You did a fantastic job presenting there. So I don't see any questions from my colleagues for Chief Goldstein or Chief Kaufman. Lastly, I just want to make a note. I really want to thank our hospital partners who came back on in this session. Ms. Aaron did a phenomenal job through Nexus Montgomery representing the general views of our hospitals. And Nexus is such an important organization and so unique to the county. And the fact that our hospitals work so collaboratively with themselves, even before prior, to the pandemic, has really laid an infrastructure and foundation that has uniquely positioned Montgomery County to better weather the storm than most other communities. And Nexus is in many ways the glue that brings them all together, but they do really fantastic work. So I do want to deeply express my appreciation along with all of my colleagues to our hospitals. We know you are all being overwhelmed right now, particularly with personnel issues. You all must be exhausted. When you Google exhaustion in addition to Dr. Kroll, it probably includes everyone on this call and everybody on your teams. But thank you all so much for being with us this morning, and we hope that you will provide recommendations, and maybe we can do these through Ms. Aaron for recruitment and retention for frontline personnel, especially in the mental health space, because that is such a crisis at the moment. But if there are other ideas that you all may have in other key areas, that would be helpful as well. So, Ms. McMillan, thank you. You did a fantastic job putting this panel together, putting this packet together, leading us through all of this. And thank you to my colleagues for participating this morning. And with that, we are adjourned.
And receiving love and care and a facility that meets the